Hello and welcome to the Journeys with PDA Coffee Chat podcast, where we seek community connection and co-regulation while chatting about all things PDA.
Good morning.
Good morning.
We are here today with a special guest to chat with us about PANS, PANDAS, and PDA, which we get questions about all the time. And we are just going to let her introduce herself and then share the information that she has to share with us, and then we'll go from there. Welcome, Joy.
Yes, thank you for having me. I'm so excited to be here at Journeys with PDA. So my full name is Joy Eberhardt DeMaster. I am a board certified pediatrician and have specialized training in development and behavioral, and love integrative pediatrics and looking at the whole picture for kiddo. I go by Dr. Joy because it's easier and fun, and that's how I introduce myself to families. I started Orchid Pediatrics in 2021 because I'm a parent and my work situation was not letting me be with my kids the way I needed to. So I started Orchid Pediatrics and really tried to create a clinic and a support for families that I would want as a parent. And so very parent-led, neurodiverse informed, PDA affirming, and root cause. So I would say we listen, we take time, and we dig deep.
And Joy, do you practice in multiple states?
I do. So Orchid Pediatrics, I opened in 2021 and it was based in Oregon and Washington at that time. So I'm fully licensed in Oregon and Washington. I'm also licensed in California and Minnesota. And then about 2 years ago now, my partner got a job in Atlantic, Canada. And so we actually live in Atlantic, Canada. And I am licensed throughout Atlantic Canada, and so I also see kids in Nova Scotia, so on the other side of the coast. And yeah, so that's me. I always like to keep it interesting. I also do some social media at the PDA doc, and I kind of have a love-hate relationship with social media. It's good and overwhelming and all of those pieces. And in the process too, with my kids getting assessments, I also learned I'm like, oh, I am got an autistic assessment and diagnosis. And then when I found PDA, it actually just explained everything with my parenting experience. And I always thought I was a little it just didn't, like, my parenting experience just didn't fit anything, and I just didn't have a word for it. And so when I found PDA just a couple years ago, I was, maybe even just a year ago, I was just, oh, this explains why. Yes, it all. And then yeah, exactly. It just is normalizing. So I love to talk about PDA and support PDA communities and families and bring in the intersection and of what I know medically. And also, like, I tell families, like, I don't know your life, your experience. I can share my life, my experience, and bring my knowledge to this. But this is such an important and also new conversation.
Yes.
That needs to be talked about more and more. And I did a talk for like Masterminds with Mast Cell recently, and I just really try to pull in the PDA. And what I like to tell families and talk with families is, we talk about neurotypes, but is it really a neurotype? I think it's a body type. And how the body presents in the world and in how it reacts. And so there's so much. I also just love to call out. I don't really know her personally or them personally. All brains belong, but they just do such beautiful work about everything's connected to everything. And I know, that's just how I think about it. And so when I was preparing for this talk, it's just like everything's connected to everything. PDA, PANS, PANDAS, let's have that conversation. What does that mean? I won't have all of the answers, but this is a really good starting point. And at the end of the presentation, I'll have a QR code where families can download a handout where it kind of pulls information from the presentation. And I always like to think of it as a fridge sheet. Like, who
Right.
has
Yes.
anything longer, more doable than a fridge sheet? And so it's one page fridge sheet where you can just do like 1, 2, 3, 4 and really make it accessible and doable for families. So yeah, that's my long introduction.
That's amazing. No, it's perfect.
All right, so this is me with Orchid Pediatrics. I like to say where kids thrive, we try very hard. And so PDA, PANS, PANDAS, and really looking at this as a parent roadmap for sudden change and within a PDA affirming lens. And a lot of these other pieces I already talked about, Dr. Joy, the PDA doc, Orchid Pediatrics, and I'm presenting this here at Journey in PDA. And this is a recorded Zoom talk. I acknowledge that as well. Oh, and then the other piece too, I'm just going to go back one more. I'm thinking this will be about 40 minutes and maybe less. And then really having a bit of time answering some questions that were submitted ahead of time. And I think we also talked about me coming back another time where we can just have it a live Q&A. But this is what, what's happening today. So I also have to acknowledge that this is educational only. This does not replace medical advice. Anything that you hear here, please do not change your kids' management or treatment just because I said it, because I don't know your kid and I just don't want to cause any problems. So this is, looking at it as understanding for kids. So, so the thought is, maybe you understand your kid as much as, PDAs are always throwing curveballs at us and trying to understand, but maybe, you have the thought like, okay, this is my kid, this is going on. And then suddenly you didn't. Like, what is happening now? Maybe, sleep is just incredibly difficult. Maybe suddenly your kid was a picky eater, but not only is it not a picky eater, but they're just really not eating, big emotional outbursts, can't go to school. Sometimes kids can have movements, and so sometimes it can be, sounds in their voice, or sometimes what are called like motor tics, so how their face moves or their body moves. And then just really these thoughts, which sometimes it's hard for us to know as parents, that can really control a kid's life. And so the thought would be is, how do we look at PDA stress and then look at it the lens of, okay, PANS, PANDAS. And when we say PANS, PANDAS, what we're talking about is we're talking about kids having many times an infection that's really causing big changes overnight that's affecting their behaviors and their well-being. So the thought would be is, what to do next from here. So I want to I imagine most, if not all, know what PDA is, but I always just like to address that and talk about that briefly, talk a bit about PANS, PANDAS, what it is and what isn't, and then really talking about the real overlap, which is interesting, and also not well, I think, and not talked about enough. And so the hope would be is leaving with a plan, giving ideas for how to advocate for your kid, and then calmer next steps. And then really also recognizing that when we're thinking about PANS, PANDAS, and sometimes I use the word basilar encephalitis. And the reason I do that is it makes it more real for doctors. If doctors hear encephalitis, they think brain infection. If they hear PANS or PANDAS, especially PANS, they just might hear, oh, something hokey pokey. Don't know what it is. Either I'm going to ignore it or be upset. And that's usually how doctors react if they don't know something. So basilar encephalitis is another term. I don't think I have this in my presentation, but that is something. And so when we're thinking about if your kid's brain is on fire, what to do and how to look into that. So when we think about PANS PANDAS, it really is, sometimes as quick as overnight where a kid changes. Their eating changes, their behavior changes. They are so stressed, they are not themselves. Maybe they can't go to school, or maybe they go to school, but they are at home is even worse as well. And so, it can look like an overnight, this is not my kid, anxiety, panic. The intrusive thoughts can be difficult because a lot of times kids, like, it was a parents, like, who knows what's an intrusive thought? What I talk about with kids is like, do you have sticky thoughts? Do you have thoughts that you don't want? Do you have thoughts that don't go away? And so that's a big piece. And when we think about basilar encephalitis, we think about PANS PANDAS, it's kind of like an OCD on steroids. It's these the brain is just controlling the kid's ability to live life, and it really is limiting a function. Um, Commonly, it also handwriting completely decompensates. A kid can go from being actually a really great artist to not being able to draw. Common is kids can suddenly kind of draw down to kind of like a diagonal. That can happen as well. Just high sensory overwhelm. Peeing issues. Suddenly, if a kid suddenly starts wetting themselves, it's not, yes, you want to look for a urinary tract infection, but even if there isn't, if a doctor's like, oh, there's no, UTI, it doesn't necessarily mean there isn't a problem. It just means that there isn't a UTI. So, and then sleep is just a big piece. It can be kids going to sleep, maybe staying asleep. It can be too, with the anxiety too, of kids really having a hard time separating from their parents. And so like they're glued to their parent. And so in this too, I think I have in my presentation just a brief mention of, what do we do as parents when our kids are struggling? And because it's not just seeking help for them, but it's also for us too. So PDA and the how to describe this, I feel like there's so much controversy and nuance and who says what when. So I just want to call that out. The name initially came from pathological demand avoidance. I like the term persistent drive for autonomy in regards to that. And but I also like to use the word demand avoidance because I think that's more understood from people. And it's really what I describe to parents. I do ADHD and autism assessments, and when I'm looking at PDA, I tell them, your kid, when you ask them a question, when you compliment them, when you ask them to do something, that is something that they need to take in, and it can cause their body to be stressed. It's not something that they're choosing, but what it does is um, it can almost create a panic or overwhelm. And so to help them regulate their system, to help them feel better, the answer is no. And really what it is they're trying to be like, I need to breathe, I need to slow down, I'm overwhelmed. And so what I encourage parents to say is, okay, when a kid is saying something, what are they actually meaning with what they say? And really looking at behavior as communication. And I think you all probably know connection before correction, finding ways, as far as autonomy, and really giving kids the ability to collaborate in all of this. It is a completely different way of parenting, and the world will judge you very much so in this, but it can really help kids regulate their body, their nervous system. So what we want to think of is if we have a kid, we're assuming they are a PDA-er, and before there's any concern for PANS, PANDAS, any concern for basal encephalitis. How do we tease this out if a kid already, maybe is baseline anxious, maybe is having some sleep struggles, some struggles at school? What do we know? How do we know what's PDA and what's PANS, PANDAS? So one of the ways to think about this, and there's so much nuance to this, when we think about PDA being baseline, true, it is there, but we also know, as parents, how our kids are sleeping, how our kids are pooping, how their kids are eating, kind of changes that baseline fluctuation. And so what I would think about it is it's more of the how large the sine wave is, or how large the variance is in the baseline. What we see with PANS, PANDAS is it's really and can be it's just a really night and day difference, where it can be a kid like can't go through a door, or suddenly is peeing and wetting themselves all the time, can't separate from a parent. uh, it's beyond what would be expected for a child, and maybe they lost the ability to do something such as handwriting and those pieces. And it's not necessarily one or the other. It can be both. Um, so looking at the nuances in this, and I think this is where it's so important for medical professionals to listen to parents, because as parents, we know the baseline for our kids, the variances in how they're doing, and medical professionals don't. And so I think this is where the being listened to as a parent is just is crucial. So overlap is real. Yes, you might see this in PDA and in basal encephalitis. And I was like, oh, I'm not very neurodiverse-affirming here, but calling rigid thinking. Because what I tell families when kids need to have something their way is the sense is that they take in so much sensory wise. And so by doing something a certain way, it actually regulates them. The other piece for PDAs is sometimes they don't want things done the same way. And so that it's just the piece of all the more so knowing your own kid. But really is really, again, looking at the baseline for a kid, and that this is something that's always been there, but how it shows itself may be different. When we think about basal encephalitis or PANS, PANDAS, there's something that triggered it. The PANDAS term is specifically from a strep infection. So strep throat is a common one. The kid itself does not have to have strep throat. It can be a parent with strep throat, maybe even a siblings with strep throat. And what that does is it changes the kid's immune system, and it just puts their brain on fire. So it is a trigger. And the trick is that when there is this very quick change, finding that trigger and addressing it. And again, the history is everything in this. So it's so important. This is a somewhat helpful slide. I feel like I need to flip it around a bit, but it's trying to demonstrate baseline versus the cliff, this is more of a mountain than a cliff. But really, when we're thinking of how is a kid normally, and this is where we're going on, maybe there's ups and downs, and this day is harder, this day is easier, but all of a sudden it is so much harder, and you're like, wait, but we would normally be here, and maybe this day is going to be harder, but it beyond what would to be expect. So fast change. What do we see in the body? What is the illness exposures? And the thing to keep in mind, which so often can happen, is that as a parent, this quick change happens. And this is actually maybe more, well, for parents, but also other professionals, is you can get used to this as being your new baseline, and you forget about down here. So I think sometimes, if you can think back to when life was easier, that is important to remember, and remember, oh yeah, remember that time when this actually could happen. Whereas you now are living here where, maybe a parent can't really leave the house for, a kid can't draw, but now maybe they can draw a little bit more, but not to where they were before. So it's really, we want to get back down to this baseline and not live up here, not forget about when life was easier. So, and I feel like this is a bit repetitive, but I guess that's how presentations are. So, with red flags as far as evaluation, again, sudden changes. And it doesn't necessarily have to be like, oh my goodness, I have to wash my hands all of the time. Oh, I'm worried about germs or bugs. It can be, I can't eat this food. It can be just a lot of big emotional outbursts. And it just depends on how much a kid is able to describe their own internal experience. And if we think about for ourselves as adults, how much of a struggle it can be to understand our internal experience. And then for kids, it can even just it can be hard for them to know. So really looking at, how are they behaving? What are, maybe are they doing lots of baby talk now? You know, are they losing skills? What's happening overall, the picture, um, and seeing all of these new pieces as they come out. So yeah, so looking at sleep, looking at voiding is what I say, and it's usually more pee than poop. Looking at fine motor, so handwriting, drawing, those pieces, looking at that social, um, um, able to separate from parents, how are kids communicating, and what I just would encourage all parents is, if you think this is not my kid. I mean, this is your kid, but like if you're like, this is not who my kid normally is, this, please document all of the changes you're seeing and talk with your doctor and at early as possible. Because if we think about, if the brain's on fire, we want to calm it, we want to treat it sooner rather than later so it can heal. And this is the struggle. And so when you all reached out to me, I was like, yes, I want to talk about this, because I've had parents ask me to talk about this, and because it's so easy as a parent to get dismissed by the medical professionals, and they mean well, right? But they're like, well, this is autism, this is ADHD, or, oh, your kid's going through puberty. And the interesting thing with puberty is it's actually an immune compromised state. So kids that are going through puberty are more susceptible as far as to infections is how I think about it as well. So, this is anxiety. Well, yeah, maybe, but what's the cause of anxiety? And my least favorite is they'll grow out of it. I've yet to see my kids grow out of it, but I guess maybe in some other universe that happens. But basically these are minimizing what a parent is experiencing and trying to give it a name. And I think what happens many times is that doctors are trying to reassure, and it's just really not helpful. So, one thing would be is if you give the timeline, if you use the words basilar encephalitis, if you talk about sudden, if you talk about lost skills, that really perks up doctors' ears. And then, you could say nervous system, but it's also a body shift. These are changes, timeline, baseline versus the sudden cliff or the sudden change. And then, as annoying as us as doctors can be, and I many times apologize to parents for the medical professionals, and I know medical trauma is real. Please look at the professionals you're dealing with as to advocate and not adversarial, because it just makes it more difficult. That said, if someone isn't listening to you and you're not getting help, go elsewhere. But really looking at advocating with the clinicians that you're working with. And then act quickly. This isn't something that you want, and this is the struggle when people are like, okay, if we go back to the next one, oh, it's just a behavior, right? They'll grow out of it, or it's it's anxiety, don't worry about it. What happens is it delays assessment, it delays treatment, and that matters. So, as a parent, you want to get help right away, and what you want to do and bring is, okay, date and time, when things happen, when things change, what has changed. And if you can keep it to one page, doctors appreciate that because they get overwhelmed with anything longer than a page. And bullet points are much more appreciated than paragraphs because they also, I don't know, doctors, I guess maybe go into medicine for a reason, right? We don't go in to become English professors, and we can't read paragraphs. Anyway, I just say that facetiously, but bullet points work much better. And then some photos or videos. Please pick one or two and favorite it before the visit. It just the visit will go better, is what I would say. I mean, these are asks, and so if you can favorite it, but it can be helpful as far as seeing the differences. And then if anyone else has been sick at all, and this is, as a parent, this is a lot to ask of you, because ideally you just, you go to a doctor and say, hey, my kid's having a hard time, they're upset, they're peeing themselves, and then the doctor helps you. But the reality is that it's PANS is not very well understood. And so I think as a parent, you do need to have a certain awareness if you can. So testing, what to ask for. And I struggled with this because we could do a whole talk just on testing. And so this is cursory to say the least, but really looking for strep testing, and really want culture testing, because if the doctor gives you the answer, oh, there's no infection at the visit, that's the wrong test. They can give you the result, but say, okay, we're going to send it out and so to be the right test, they need to not know for sure. But if they do the tests and seems like it's strep, other people have had strep, like, you don't have to wait for antibiotics. You can start treatment while you're waiting for the test results. And then this is the other piece too. What do you test for strep? And, is it just, and again, this is a whole nother talk, but is it just group A strep? No. Not only is it the culture, but you're really getting into the back of the throat, what's called the really got to gag the kid, right? If they don't gag, it's not a good test. And then looking at perianal as well. So looking at the butt, sometimes strep can live in the butt and send that culture. Sometimes it can be in the genitals as well. And so that's a piece too. And then one of my colleagues also taught me about looking for staph in the nose, and that can make a big difference for kids as well. So these are swabs, these are not blood tests. And so this is a way that, if a kid really struggles with a blood test, then you can still get these done. The other thing I would tell parents, and my little trick, is always throat swab. So throat swab last. Even if a kid is the most resistant to the butt swab, throat swab is 100% the worst. And if they do the throat swab, it's usually the end of the visit, and you're not going to get any other swabs. So and then the other piece is, if you do need to do the butt swab, the kid can do it many times. It's not that big of a deal. So, just if we're talking about PDAs and having autonomy, let them swab their nose, let them swab their butts. And it's just in the, outside, nothing inside. But the one thing I am strict on, and this comes from a kiddo myself, had 4 people hold me down to get a strep test as a kid. I remember it vividly. But you have to have a professional do the throat test for it to be valid. And if you find someone really good, they can do it really good without holding a kid down. I am excellent at it, and because I know the experience. But if you want to help the doctor, if they don't know, your kid needs to be ideally flat, laying down, or on some surface where their head can't move. And then just be able to get in the throat and swab it back and forth really quickly. And so what happens if you try and you fail, then that's what requires the holding. So just succeed the first time is my my take on it. So yes, obviously I'm still a bit scarred with my own strep throats, but it really matters because if we're talking about PDA for kids and we want to give them autonomy, and if they say, oh, can I do this themselves? Be like, this is the task that the doctor has to do, and you can explain how they do it, and if a parent, if you're there and you can get your own test swab as well, that could be potentially helpful, but really it has to be a professional that does the throat swab. And then speaking of also, parents should get the swab, the culture test. I don't necessarily say that the other tests have to happen, but really looking for strep. Labs, blood test is ideal. There's any number of different tests. It's not always strep, sometimes other pieces. So if you can do some blood testing, that is usually advisable. But very, very least doing the swabs. And then really looking for safety. If a kid is completely changed, if they're not safe, they're not safe for themselves or others, acknowledging that, having a safety plan, what do you do, and then also really looking at, okay, this maybe your kid really can't do well at school now, and really acknowledging that, and what does that mean, getting those supports from the school and having the school aware of that. All right, moving on. So what your clinician might look at, so timeline, and again, if this is, sometimes what happens is it's been going on for a while, maybe it's been going on for a number of years and suddenly it's just gotten worse again, and you've forgotten about that initial baseline when things were a bit better. So that's kind of that relapsing pattern. Looking for infections, baseline labs, looking for inflammation, and then also, looking for other causes. Could there be something else going on? And so when I see kids that, I many times like them to see neurology, rheumatology, other people in this, to really look at other aspects of what's happening. And then, again, this is abrupt. This is our timeline. You can say, well, how do you plan to rule out medical causes? If you go in and, you have, your kid's autistic, and, you go in, you say, hey, my kid's having a hard time with sleep. They're really upset. They're peeing a lot. This is a new change. And if your doctor's like, well, it's autism, you could just say, well, how do you plan to rule out other medical causes? When we're looking into this, and, I'm worried about basilar encephalitis. And then, seeing what can you do to document school impact? Is there a letter that needs to be written? And then this slide specifically kind of talks about what I think about the 3 legs of the stool. To sit on a stool, we can't sit on with 1 leg or 2 legs. We need 3 legs. So when we look at treating basilar encephalitis, so we look at treating PANDAS, we have to look for the infection. So we want to look for the triggers, and then address that, and then reduce the triggers. And then I guess this kind of fits a little bit more under support. But then we also need to calm the inflammation. And so, let's say we find strep, we treat the strep, that's great, but we also might need to give something for inflammation. And so sometimes that can be over-the-counter ibuprofen, and that can be helpful. We also have to remember that, we know our kids are human beings. And also what needs to be remembered is supporting their suffering and their symptoms and what's going on. So if they're anxious, overwhelmed, great, we can treat the infection and the inflammation, but we need to also look at how do we treat the anxiety piece. And it is all related together. So, sometimes that's therapy, sometimes that is medications, SSRIs, and it can be just super low dose, and that can make a big difference, different supports and accommodations. I kind of hate the word accommodations, accessibility, but you know, as far as at home and school and what that means. And then this is a little bit more that's already more PDA, but I think kind of just really having to pick, okay, safety, you know, you really need to focus on the essentials of sleep, fluids, which is like water, hydration, and food. So, and everything else is like, is gravy, is everything else is like, is, oh, that's nice. But, you know, really focusing on the real basics in regards to that. And really, you know, as parents of PDAs, and we already have to drop a lot of expectations, but really within this, you even have to drop more. And in regards to when it, you know, what is your kid's capacity at this time? What is your capacity? What is your ability? And so really looking at ways, you know, safety, and then making sure kids are sleeping, eating. I guess pooping isn't in there, but that's another piece as well. And then, you know, going back to the language, which I imagine everyone's very familiar about, the collaboration, you know, indirect, and you know, some of this works for some kids, you know, but, you know, talking about ways of scaffolding transition. So, and that still all is, you know, still can be a piece of it. Schools, so schools, it's important, you know, whether your kid, you know, goes to school in person or school at home, you just recognizing that it's going to look different, learning is going to look different. That's, and then just, you know, possibly talking about, you know, updating if you have a 504 and IEP, you know, what that would look like. And I think this is an important piece too, is that unlimited access to the bathroom. And I think sometimes schools are like, oh, kids are just trying to take breaks. But the whole peen thing is a real thing with basilar encephalitis, and making sure that they're able to go to the bathroom if they're, you know, if during a flare they're able to attend school. And then family survival skills, you know, it's just so important to say, hey, it's really hard right now. And you know, this is a hard time, and there will be easier times. This is, you know, and then just trying to, yeah, trying to get some space and all of this, asking for help. The really hard thing with anything that's more mental health is that many times society doesn't offer supports. If it's cancer, other pieces, you know, everyone gets meals and, oh, let me help you. It's just because I think there's stigma, but it's just not understood. So, you know, you still deserve that as a parent. And the thought would be is, yes, I would hope for that, you to be able to get that. Lower your own expectations for yourself, choose your musts, what you need to do. And, you know, really realize that you're not failing, you're responding to a medical storm. It's not easy, but really just looking at this is where you are now, and needing to address it. So hope with honesty. The reality is of basilar encephalitis, it doesn't necessarily always go away, and kids don't always get back to baseline. Sometimes they do, sometimes it can come back. And really looking at, you know, when there is a sudden change for your kiddo, for all kids, right? We need to look at it in a medical lens. And this is even for neurodivergent kids, for PDAs, getting support. It doesn't replace the evaluation, but it is incredible, you know, having those support strategies. And you can also be, you know, validated and proactive, you know, for yourself or with clinicians. You can have a clinician say, I see you, this is really hard, and this is what we're doing. It's not just like, oh, I see you and this is hard. So that's the hope. And realizing that, you know, neurodivergent kids are more likely to get basilar encephalitis, in the piece of this. So, you know, for those hard days, you know, make it smaller, make it safer, and make it together is what I would encourage you all to do. Couple of different resources, the PANDAS Physician Network, There's some information on PANDAS. I don't actually have any links here, unfortunately. And then, no crisis support is there, and it is okay. It is okay to use it. What to say to school and what to survive the mornings. Could you, one of you jump in and share with me? I think there were two questions that I wanted to try to address.
Yep, I will share. So the first one was, how can we tell the difference between autistic burnout and PANDAS in our PDA child? Do we treat the two differently? Is there a benefit to trying different healing approaches, psychiatric versus homeopathic? So really that's multiple questions. So first, how can we tell the difference between autistic burnout and PANDAS in a PDA child?
So the way I would describe it is that with autistic burnout it is a lot more gradual and it's not sudden. So when we're thinking about PANDAS, it's a very, my doctor term is acute onset. It's something that's many times happens overnight or within a couple of days. Autistic burnout is a slow burnout where things many times can get more difficult. But yeah, I mean, there's a nuance to all of that, and what does that mean? But that would be my quick answer to that. And then I think what was the other question about different modalities?
Do we treat burnout and PANDAS differently? Which Heather and I can actually speak to that a little bit based on the presentation.
Okay. Yeah, I would say yes. Yes, you do treat it differently. So
yeah. And then is there a benefit to trying different healing approaches, psychiatric versus homeopathic? I think maybe Western med versus homeopathic is what they're referencing.
So I think about that in, 100 years ago, we had allopathic, naturopathic, and homeopathic as different modalities of looking at treating and support from the medical aspect. Over the past century, the allopathic, which is the Western medicine, has definitely become in power and has been the strongest voice. And then the naturopathic is still present, and then the homeopathic as well. What I can say is that I'm not trained in naturopathic or homeopathic, but what I can say is I think that when we're treating an infection, I think antibiotics are the best choice for kids. And I have some really great naturopathic colleagues that would back me up on that. I have also seen kids when we do antibiotics and we're really struggling to find, what infection is this? What's the trigger? And I have seen kids get support from homeopathic and been tremendously helpful in all of this. So my biggest thing I would say is if it's an infection, if you find strep, please, even if you hate Western medicine, if you hate antibiotics, please give your kids antibiotics. And then also look at other ways, modalities for support. But yeah, looking at those trios and how they all can contribute to well-being or support for your kid. I think they all have something to contribute, but many times they do it separate from each other, which I think is a really loss overall. And so that's one of the reasons I really like integrative pediatrics, is I don't know all about all of those different aspects. I 100% don't know everything, but I have an awareness. And so I try to look at those different approaches as I'm seeing kids and families and being open to different modalities.
Great. This next one is kind of long. I'm trying to break it down into parts a little bit. The first question was, how do you differentiate between PDA and PANDAS, which you spoke to some. This parent has pursued PANDAS treatment, done 12 rounds of IVIG with their child. Seemed quote unquote normal, and then a sudden uptake about 7.5 years old. Could this child have been autistic and very high masking and just made it as far as he could and then fell apart? Or is it for sure how do you identify if you have a very high masking autistic child who reaches their breaking point, or if you have pandas? Both could be causing an escalation.
Yeah, so I think a lot of that can be history in regards to that. And so talking with the family, and what I would say is that, if there was no differences and no PANDAS does not cause, well, I don't think it causes autism. I think it causes the differences as far as in the brain. I think what I would say to that is that would be, you would want to see a neuropsychologist as far as doing an assessment, someone breaking it down. But the other piece is, I've done training with the Neuroimmune Foundation, and many times what I hear from them, and again, this is, I can't say specifically about any kid, but many times what I hear from them is that after you've done like 4 courses of IVIG, that's when you usually see a benefit or not. And so it's typically, that's the sense. And so then looking at other, what would be the word, the other differentials, other pieces that could be going on. So that's why I really lean heavily on kids seeing rheumatology, and so looking at, okay, what are other, what else could be going on, other testing? Because whatever treatment it is, if we keep throwing the same treatment and it's not making a difference, and sometimes it can make life even worse, it really is important to step back and look at the whole picture and evaluate. So it sounds like, whenever a kid has had lots of treatment and it's not making a difference, or there's not diagnostic clarity, sometimes it's a matter of getting more evaluations and getting more information as far as to move forward. And the piece I would say about IVIG is it's not benign. I've had kids that take it, and it's, it can be helpful, but it also is definitely very much a treatment. And so looking at like anything, the risk benefits. Work, 4 rounds of IVIG is my understanding. We should see a benefit at that time, and then needing to reevaluate the diagnosis, looking at other possibilities, and doing further assessments can be helpful as well. So I have the handout here if people are interested in downloading with the QR code, and it just breaks it down with different red flags, the 72-hour plan, giving some ideas of how to seek some help and support. There's also the link here for those of us that find QR codes very much a headache, but that is the piece that I just wanted to share with you all. And I love sharing what I know and moving the understanding for the PDAers, the PDA community, because I think it's incredibly important. And so I just would say for you all, or any other parents, if you know where I can talk and speak, please let me know. I'm very passionate about this, and looking at creating some courses as well, just to make sure that there's more understanding as we move forward into this life.